Good evening. My name is Dr. Gori, and I am the vascular neurologist here at JFK Medical Center.
Good evening. Thank you for joining us. My name is Haralabos Zacharatos. I'm one of the interventional neurologists at JFK Medical Center. I also practice vascular neurology and neurocritical care.
Hello, I'm Brian Jankowitz. I'm a cerebrovascular neurosurgeon that specializes in the endovascular treatment of stroke.
So the topic of our presentation today is wellness, particularly women's wellness and stroke. And the way we have organized our presentation is that initially we're going to give a little bit of an overlook of what exactly is a stroke. We will try to help our audience understand what is the meaning of stroke, and what type of strokes we encounter in our day-to-day practice. Then we will move into the unique risk factors that in which the women are at risk of, and we will also in the process discuss the risk factors which are common to both men and women, followed by our final section of the presentation in which we will give a little briefing about how we deal with these type of strokes and what can the general public do to prevent these kind of strokes from occurring, and if they do occur, how to manage them. So without further ado, with our first slide, what is a stroke? So in layman terms, a stroke is when one or more of the blood vessels that supply our brain tissue get damaged. The two most common type of strokes that we encounter in which we could damage our brain tissue is the ischemic stroke. Around 80% of our strokes are ischemic strokes, and these occur when one of the blood vessels or more than one blood vessel has some kind of an obstruction. It simply means that a clot lodges into the blood vessels and it prevents the blood from supplying the blood tissue beyond that clot or the point of blockage. Second is a hemorrhagic stroke. The name is self-explanatory. It means that there is a hemorrhage in the brain, that is bleeding in the brain. Usually occurs because one of the blood vessels or more than one blood vessel supplying the brain tissue could rupture and hence result in this bleeding.
When we say stroke, most people probably think of ischemic stroke, and that's probably correct because the vast majority of strokes in the US are ischemic, maybe 80 to 90%. But the good news is we've been making great strides, not only in the treatment of ischemic stroke, but even in hemorrhagic stroke being where you bleed into the brain. So we have exciting technology to help treat all aspects of intracranial stroke.
This is actually a continuation of the same slide, giving a little closer look as to what is happening in our blood vessels. Towards your left is the ischemic stroke. Inside the blood vessel, we see this yellowish structure. It looks like a clot, and it is a point of obstruction. And then the blood vessel breaks into two additional vessels. The blood from the main vessel will not go beyond this clot into the other two blood vessels, and in the process, the brain tissue that is supplied by those two vessels is going to be compromised, depending on the duration that the clot sits there. On the right side is the hemorrhage, where there's a little bit of a snippet as to if a small blood vessel breaks off or ruptures, the blood pools into that brain tissue, causing strokes.
So to simplify it even further, when somebody says ischemic stroke, it just means that there's limited oxygen or no oxygen going to that part of the brain for which that blood vessel is blocked. A hemorrhage just means you have unexpected blood in the brain, and it's outside of the normal blood vasculature, the blood highways that it normally travels into.
This is a picture of what we look at when a patient comes into our hospital with a stroke. This is a picture of an MRI. And the area of the brain which is bright, the white area, that is where the stroke has occurred in the said patient. Another phenomenon that a lot of times people encounter in the clinics is you'll hear us talking about transient ischemic attack, or a TIA. TIA is simply put blood vessels trying to have a stroke. which means that a patient could have symptoms which are exactly like a stroke, which could be a facial droop, going completely weak on one side of the body, having vision difficulties, all the symptoms of the stroke. However, these are reversible symptoms, which means that they resolve within 24 hours. And another important thing which differentiates a TIA from a stroke is that we do an MRI, and if despite the symptoms resolving, if we see a little hit on the MRI, if we see a stroke on MRI, then we don't call it a transient ischemic attack. We actually call it a stroke. Um, uh, but if the MRI is negative and we do not see a stroke on it and the symptoms have resolved, in that instance, we call it a TIA.
So a person that comes in with a TIA, they can look relatively normal. But then it comes down to asking the question of, well, what happened? Did that person lose sight in their vision for a few seconds, for a few minutes? Did that person lose the function of their arm or their leg or inability to talk? It could just be so temporary, they don't think about it or they ignore it and they go to sleep and they just go on their normal day. Well, we are so often the receivers of people then that come to the ER and with bigger strokes because the TIA was the foreshadow, the event that was predicting the step next that was going to happen. Because once you have a TIA, then you have a higher chance of having a lack of blood flow type of stroke in the next couple of weeks. So a TIA is equally as important as a stroke. And that's important to know, especially if you have somebody that is in your family that says, you know, something would happen with my vision. Because then potentially that vision could be a blockage in the carotid artery. And then that's something that Dr. Jankowitz can repair by opening up the blood vessel, cleaning out the blood vessel. We'll get into those details as we go on.
Just a little bit of the duration. Most of the TIAs that we encounter last for less than 60 minutes. Very few instances when they go longer than that amount of time. This is a picture of a CT scan. Essentially, this is the imaging that is the first imaging that we do in patients as soon as they come into our emergency room. Interesting to note that whether you have whether a patient has an ischemic stroke or a stroke because of the brain bleed, both of them could have the same kind of clinical presentation, which means that in both cases, patients could have a loss of function in one side of the body, which means paralysis. They could have dizziness, like spinning sensation, facial droop. And so it is the CT scan, which is the first test which basically helps us to differentiate whether it is a brain bleed or if it is ischemic stroke. And this is very essential because the treatment of both the types of stroke is going to be different. So this is one of the most important tests that we do as soon as the patient is wheeled in with a stroke.
And why CT scan over MRI?
CT scan over MRI because it's faster. Most of the a lot of facilities might not have MRI readily available. CT scan is easier to do. It takes shorter amount of time. Also, a lot of patients have issues with because MRI is a closed chamber. Some patients are agoraphobic and they are scared of going into an MRI machine, so we have to sedate them. So right as they enter in, this is a very quick method of screening them and getting an idea of what's going on.
And if anybody watches what happens when somebody with a neurologic change comes through the emergency room, there is a fine interplay of multiple disciplines converging on this patient. The nurse, the charge nurse, the neurology resident, the ER doctor, the vascular neurologist, the interventional team. Everybody's goal is to try to reduce their time from coming into the door straight to the CAT scanner, so we can determine, is this person having ischemic or lack of blood flow type of stroke, or a bleeding type of stroke, or some other process that's causing this neurologic change.
Here is a picture of a brain. This is to give our audience an idea of how our brain is divided. This is just a general idea. We have lobes in our brain, which and different lobes control different functions. And depending on what location of the brain is affected, that function of the brain could be impaired if the stroke occurs in that area. For instance, the lobe that we see right in the front of the brain is called the frontal lobe. And why it's important from a stroke perspective is that many patients, if they have a stroke affecting this area of the brain, will have speech difficulties, and particularly a kind of speech problem where they will have difficulty articulating. It could be occurring at a different, to a different extent. Some will be able to articulate words, but the fluency is going to be impaired, and others would not be able to get any words out. And it could be an extremely frustrating situation for the patient because they're aware of what's happening around them, but they're not able to express themselves. Another lobe, which is right behind this frontal lobe, is labeled as a parietal lobe. And this is our sensory center of the brain. We perceive all the sensations in our body, and they're interpreted in this part of the brain. And so some patients could experience stroke symptoms, which are simply where they say that, doctor, I feel that one side of my body is completely numb. Also, this part of the brain controls another aspect of speech, which has to do with understanding speech and comprehension. So patients who have strokes in this area could be seen speaking fluently, but the words are not making sense, what we call a word salad. However, when you're going to talk to them and you're going to try to give them direction, for example, we tell a patient to raise their arms, they won't be able to do that. We ask them what day it is, they will have no idea what you're asking them, and they'll have no idea of their whereabouts. There's a tiny lobe at the back of the brain called the occipital lobe. This is the lobe which perceives, it's responsible for vision. Generally, people think that it is just the eye and the front of the brain where most of the vision is happening, and the retina. But in fact, everything that we see in our life, everything which is within our vantage point, it is all perceived in the back of the brain. The image actually finally falls onto that back of the brain, which is called the occipital lobe. So if there is a stroke in that part of the brain, patients could have a visual problem where they might not be able to see one side of one half of the vision. Visual field could be affected depending on which side, the right or the left lobe being affected. There is another lobe which is called the temporal lobe, to have an idea, over the ear area. And this temporal lobe is responsible for memory function. It also recognizes faces, and it also perceives the hearing stimuli. What all we hear, it is perceived in this part of the brain.
I'm still fascinated by how sensitive the brain is to the lack of oxygen, and how quickly some function completely erases when you lose that oxygen, and then how it comes back at times when you improve that blood flow. So it's a very fascinating, and probably the most sensitive organ we have in our body, but we're biased. This is an example of a main blood vessel that provides blood to the brain. This is the lower part of the neck. It's called the common carotid artery. And as it goes up, it's called the internal carotid artery. That's an example of a normal diameter and what it looks like from the way we see it. These are also normal blood vessels in the brain. I think it's good for you guys to understand what it looks like as a normal structure, because as we talk about this is something that we look at every day, and we look to see the abnormalities. But some of the risk factors that you're going to hear about: high blood pressure, obstructive sleep apnea, high blood sugar, otherwise diabetes, or high cholesterol, or smoking. All these interplay affect these blood vessels in different ways. So what you see here is the internal carotid artery traveling up, and right behind our eye it divides into the anterior cerebral artery and the middle cerebral artery. In between the middle cerebral artery and the internal carotid artery are these small little blood vessels called the lenticulostriate arteries. All of these blood vessels provide blood to the brain and provide and supply all the different areas of the brain that Dr. Arifo was talking about. So when you block the blood supply there, you lose that function. So that's what an ischemic stroke looks like. Now, flip side is when these blood vessels rupture, you have blood in the brain.
And to be clear, there are a lot of ways to image the blood vessels of the brain. We've talked a lot about CAT scan and MRI. This is a special test called a catheter-based angiogram. You could think of it as a cardiac cath of the brain, where Dr. Z would take a small plastic tube and inject contrast directly into the artery, which effectively takes everything else out of the picture. No bones, no brain, no soft tissue, no ligaments, and just focuses on the blood vessels. So we call this the gold standard blood vessel study if we really need to know detailed information about the pipes that bring blood to the brain.
So we talked about the front part of the circulation. This is something that's in the middle part of our brain. And this is a unique view that you don't normally get to see, something called the basilar artery. But you can think of the Garden State Parkway. If you blow up the Garden State Parkway, you block it, it completely disrupts north from the south. If you block this basilar artery, it has a tremendous effect on the neurologic function of a person.
And a little point that I would like to emphasize here is the previous pictures that we saw was of the blood vessels which supply the front of the brain. So usually public is aware to some extent of the stroke symptoms, but those stroke symptoms are mostly related to the blockage in the front of the brain, the frontal vessels that we showed before this one, which is one side of the body being paralyzed or having a facial droop or the speech problems. It is this back of the brain blood vessel, the basilar that Dr. Zacharias just showed, which has more of the non-specific symptoms, and the strokes associated with this part of the brain are harder to pick. And it would be, I would like to educate the audience about these strokes only because they'll be faster and they will not take these symptoms lightly. The symptoms of this part of the brain could be something as simple as lightheadedness and feeling weak. And this weakness is not paralysis, but just a generalized weakness. And we might think that maybe I'm coming up with fever or maybe it's some infection. And in fact, it could just progress into something bigger. Does that mean that for every weakness you run to the ER? No. But it could be a very, very crippling kind of a generalized weakness with a sense of impending doom. There could be a violent kind of lightheadedness, or initially it could start as a mild lightheadedness, which could just progress into symptoms where the room would spinning violently. There could be some vision problems. There could be nausea and vomiting. And these are some of the symptoms which are common to other medical conditions and could be mistaken for an upset stomach or something other than a stroke. So if this is something that you are experiencing and it just doesn't feel right, then trust your instinct and get yourself evaluated in an emergency room.
And I want to double down on something Geraldo said earlier. Even if you're back to normal, and we'll call that a TIA, if you're 100% back to normal, you or your loved one need to treat that as an emergency and come right into the hospital. Because in fact, those are the best patients to treat before there's any permanent damage.
Some cool tidbits to know. If you block off the anterior inferior cerebellar artery, you immediately will go deaf on that ear. We're talking about very rare cases now, just something that we talk about, but now that you have a benefit of listening to.
Sudden deafness could be a sign of stroke. Bit of an overview of what is stroke and what are the types of strokes. Let's look at some of the numbers, some statistics as to what is the impact of stroke and what are we dealing with currently. So every 40 seconds, somebody in the United States is having a stroke. And 80% of the brain disease can be linked to the cerebrovascular disease. Which means that most of the patients who are coming into our emergency rooms with a sudden issue related to what looks like a stroke or could be related to brain is because of either a problem with the heart or because of the blood vessels which are supplying the brain, which essentially could lead to a stroke, or they're actually actively having a stroke. 99% of the US adults have at least one of the 7 cardiovascular health risk factors, which means as we age, we will touch base upon these individual risk factors in our later slides. However, some of these risk factors like hypertension, high cholesterol, abnormal heart rhythm, among others, are what we're talking about in the slide. And as we age, we'll at least have one of those.
Wait, what's your risk factor?
My risk factor right now, I don't have any risk factor.
Oh, she's the 1%.
Part of the 1%.
But it doesn't guarantee that I won't develop it in the next 10 years, and that's what I'm going to certainly emphasize in the latter slide. And then 3 out of 5 Americans will develop a brain disease in their lifetime. So that's an interesting fact as well. Every 4 minutes, someone in the world is dying of a stroke. And this is a very important point, that stroke is the second leading cause of death in the world. And a lot of this is because of either a lack of education or lack of understanding of the symptoms, because if you would know your stroke symptoms, you would access care faster. It could also be because of lack of resources, or it could be because of delays in reaching out or getting benefit of those resources.
And there is a global initiative to try to educate the general population and even the medical world outside of the United States. Here at JFK University Medical Center, we have a comprehensive stroke center. So we see and we appreciate time from the neurologic change to give that person the best possible treatment and the best possible way. And we spare no expense in doing this. Outside of the US, this is different. And I don't take it for granted by being in this environment. We give our best to give this person the best opportunity, but I know friends and family outside of the US, it's harder to access this kind of care that we have here and we provide here. And so it's important to know that what you have in your community.
I'm glad you brought that up. I think we have one of the best stroke programs on the East Coast. And if you come in with a stroke, it takes an army to care for that patient. The next person that walks through that ER with a large vessel occlusion or a stroke might see all 3 of us as they come in. We might have a vascular neurologist that assesses the patient to diagnose the stroke, an interventionalist like myself that might take that clot out of the blood vessel. And then once they get to the ICU, a critical care attending like all of us that might then care for the patient when they need excellent medical care the most.
So every 3 minutes and 11 seconds, someone in the United States dies of a stroke. And interesting to note, 60% of these deaths occur, unfortunately, in women. To have a better idea of what the 60% means is that if we calculate, it means that at that rate, we're facing 452 deaths daily because of a stroke. And out of those 452 deaths, 270 are women. 1 in 5 women between the ages of 55 and 75 years will have a stroke. And very important to note that stroke kills nearly twice as many women as breast cancer each year.
What risk factors tip the mortality in favor of women? 60% of strokes occur, or stroke deaths occur in women. Do you understand why that is unfortunately against
With females, I will might touch base with this in the few later slides too, but some of the risks because usually in the until 50 years of age, there's equal risk between men and women. But beyond that, the slightly higher risk, but most women are having stroke 75 years or older. So it's pre-stroke conditions important for unfortunately, sometimes the educational, socioeconomic status, a lot of times if they're not actually independent and dependent on others' care, or the lack of access to help, there could be reasons which would sort of argue toward women not having a better outcome. Some of the other biological risks could include men having an equal kind of risk for their life, women because of their reproductive life, will have lesser of risk while they're in their reproductive years, but as we step those reproductive years, vessels are not prepared for taking that drop in estrogens, and so they don't have their collateral channels, as we say. The brain is not used to those insults, so if a stroke happens, it's much bigger initially, and the body is not prepared like it would be prepared in men, and so that could also at times contribute to poor outcomes.
Got it. But it's confusing to me because when you lose estrogen or other female hormones in menopause, your risk of stroke goes up. But then if
and when you're giving estrogen, it does too.
Yeah.
Yes, so that's why we moved to this slide, and I will explain what this means, because we say estrogen is good for you, but at the same time we're saying don't take estrogen. So moderation is the key, as in anything in life. And if we are exposed to the right amounts of estrogen, it's good for us. But anytime it is too much, it is bad. And then anytime it drops and we don't, and if it's not replenished, that too is bad. And how I'm going to explain that. Too much of estrogen is going to increase. So the mechanism how you can have a stroke is different with excess of estrogen versus the lack of estrogen. Too much of estrogen can predispose us to clotting. It increases the thickness of the blood, and mostly in the presence of excess estrogen, patients are at a risk of having clots in the body, which can result in ischemic type of strokes. Too less of an estrogen, which usually happens after menopause or in the perimenopausal phase. Basically, the protective effect of the estrogen on the blood vessels is what is going away. So what estrogen does is it protects the blood vessels. It sort of is also factoring in the cholesterol control in the body. And so when the estrogen levels drop, the cholesterol control is also sort of the balance is tipped. And now the blood vessels sort of start getting the cholesterol plaques, and they start to deposit in the blood vessels, something which would occur earlier in men because they don't have that protective effect. And that is the reason why one would ask that then why is it that I said that the risk of stroke between 59 to 79 is higher in men than women when they are postmenopausal. And the reason is, let's say right after menopause, now the cholesterol starts to deposit in the vessels of a woman. So it'll take another 10 years before it is significant enough, maybe. Whereas in men, they've been having an earlier deposition of cholesterol, and that cholesterol deposition process, which we call atherosclerosis, is occurring earlier in men. And so they're facing that risk earlier in life, among other contributing factors. So this is the slide which is describing the unique factors across our reproductive lifespan in women. So early life, I divided it into between 0 to 18 years is the early life. And one of the greatest risks is early onset of menstruation, that is menarche. And when we talk about this, usually in general population, girls have their menarche between 12 to 13 years of age. What is considered early menarche is when a child starts to have menstruation at 10 years of age or earlier. And what's late menarche is when a woman has her period at 17 years or older. At 10 years, if somebody is having menarche, it usually is not coming alone. It is usually explaining a bigger problem. There could be some other hormonal disturbances occurring in the child, and that could be associated with obesity. And in that case, estrogen is going to estrogen doesn't just circulate in the blood, but it also stores in the fat tissue of the body. So that is why higher the weight, there is an excess of estrogen in a woman's body, directly related to the weight. So a child who's obese, who had the early menarche, will have a lifetime exposure to a higher level of estrogen, and so that child's lifetime risk of stroke is going to increase. It doesn't mean that they're going to stroke out in childhood or in the young adulthood. It's just that their lifetime risk of stroke is going to increase. Young adulthood is from 18 years to 40 years. Here we have two unique situations. We divide it into during pregnancy and then while you're not pregnant. So most of the young adult women, when outside of pregnancy, the biggest factor is the oral contraceptive pills. These could increase the risk of stroke, overall risk of stroke. And that has to, again, do with estrogen dose. So does that mean we don't use OCPs? Absolutely not. It simply means that either lower doses of estrogen are used or the duration of the OCP use is restricted, or other options are used where the other type of hormones, that is the progesterone only pills, are preferred, or IUDs are also one of the options for contraception. So we try to recommend that over estrogen-only pills. The longer you take the estrogen, the higher is the risk. So it has to do with dose and duration as well. Second is the pregnancy, unique situation where in addition to having a high level of estrogen, other problems that we face which can predispose to both ischemic, which is clot-related strokes, as well as brain bleeds. Biggest factor is hypertension. Many women, actually there was a study which was conducted where it has been noted that in the last 2 to 3 decades, the number of women who are having hypertension in pregnancy has increased 2 to 3 folds. It could be lifestyle. It could also be maybe the use of substances, stressors in life, lack of resources, many factors which are could potentially be contributing to this. High blood pressure during pregnancy has to be taken very, very seriously. Have to take readings very regularly. Have to have a much closer monitoring by the obstetrician, the gynecologist as well. And this high blood pressure, if it is uncontrolled, can cause a condition which is called preeclampsia, in which case patients are not only going to have an extremely high blood pressure, which is not controlled by regular medications, but can also have crippling headaches, could have double vision, could have symptoms of confusion. And in addition to that, if there are superimposed seizures, that is when we are going to call it a full-blown eclampsia, in which case we'll have to consider terminating pregnancy and doing an emergency section, depending on what stage of pregnancy a patient is in. Another important thing which is less common is some vessel malformations. Some of the people could be born with it. These are a bunch of vessels which are present in the brain, which are called AV malformations. Dr. Jankovic deals with them, Dr. Zakharov deals with them. And many people have that, and we don't know throughout our lives that we have this vessel abnormality. And the only time we find out about them is either a person has a brain bleed or they're having an MRI for other reasons and we incidentally find them. So they're essentially silent and we just monitor them. Pregnancy is unique in the sense that our hemodynamics, which means our blood pressure has changed, our blood vessel structure is accommodating blood supply for two beings, yourself and your child. And so the blood pressure fluctuates and the dynamics in the way the blood flows changes, the pressure in the vessels changes, and that can predispose these blood vessels to rupture and cause brain bleeds. So in pregnancy, we have both the risk of bleeding because of hypertension as well as rupture of the vessels. And then we, at the same time, because of the high level of estrogens, could have an increased risk of having ischemic kind of strokes as well. Another important thing with respect to pregnancy is fertility treatments. Women in the reproductive age, many women struggle with fertility and they have to have very high doses of hormones. And doesn't mean I would not discourage patients from seeking those fertility treatments, but it's important to be aware that the risk of stroke could go up. And if you're aware of the symptoms of strokes, if somebody is on fertility treatment, they can immediately care the right help, which means that if you have those symptoms, just immediately reach to your emergency department because you are at a greater risk of stroke having that level of hormones. Some people during pregnancy also require external estrogen infusions because of inability to maintain pregnancy till the end. So that is also one unique situation where it could be at a slightly increased risk of stroke.
We might get to it in a bit, but if a pregnant female comes to our emergency department and you want to give a clot-busting drug like
Yes.
TNK, can you still give it?
Yes, so that's a very good question. Thank you for asking, Dr. Jankovic. So first of all, try to take your patient to a center where the stroke care is available. Our center is the best, especially if you have, I would emphasize that if intervention is available, that is the best center to go to. Only because we can bypass clot busters and directly take the patient to the intervention suite. In pregnancy, we get the placenta, the blood thinning medicine doesn't cross the placenta. So that blood thinning medication does not put the child at risk. It's the mother's risk of bleeding which is high. And depending on what stage of pregnancy she is, the risk goes higher. The highest risk is in the third term as well as postpartum, which means 4 to 8 weeks after delivery, when there is the greatest risk of bleeding because of if there are some retained contents of placenta, then you can bleed from there and for different reasons. And at that time, the decision could be made that, depending on the patient, if their bleeding risk is very high, we would not give a very strong clot busting medication, but then immediately take the patient into the intervention suite to remove the clot. So yes, very important for a pregnant person having stroke symptoms to come to a primary stroke center, comprehensive stroke center.
It brings a great point. Just jogged my memory. That was one evening that a young woman who was on the OB floor getting ready to give birth, and she starts having high blood pressure, and the OB scans her blood vessels, and just to look what's going on, there was a high suspicion for stroke. Her blood vessels were paper thin as our hair, but she was not having any neurologic decline at the time. So there is something that can lead to a reversible narrowing of the blood vessels in a pregnant woman's brain, and that's just due to different hormone interplays that Dr. Gori was talking about. So in this situation, what we did was we were in the hospital on standby for any neurologic change. We were ready to take her in to give her some treatment. But the next treatment that was most important for her was to work with our anesthesiologist and the OB to get the baby out. And then after we delivered the baby, we brought the patient up to the ICU, the neuro ICU. We watched her and we waited to see if she was going to have any neurologic decline, because at the moment she had the decline, we would take her in to give her some treatments from inside the blood vessel. So you have all these complicated things that we're all watching. And this doesn't happen to everybody, but we're here for the rare occurrences that something's going to be.
And we have all the
resources
available here to deal with it in a timely fashion and to reduce the neurologic deficit and hope for a better outcome.
There's certainly people that I've had with in vitro fertilization.
Yes.
We've done thrombectomies on or removal of a clot. And not everybody has a higher chance of developing this, but it's important to know that if you have symptoms and you're on these medicines, don't ignore them.
The last unique risk factor is the menopause, the hormone replacement therapy between 40 to 60 years. A lot of times women undergoing menopause, going through menopause, have very devastating symptoms of hot flashes and sweating, headaches. So these are very crippling symptoms. And the question would come then, do I not take the hormones? What do I do about it? And so as I said before, it's all about the dosage and the duration. As long as we give this treatment for a short duration of time to relieve symptoms, we're good. But the longer we take these medications, which means for years, then your risk of stroke goes up. Also, it is interesting to know that the time from the onset of menopause to the time when you take the hormone replacement therapy is also important. So women, first of all, we need to do an individual cardiovascular risk assessment of a patient in our clinics to see what their risk of having a stroke itself is in the without taking menopause into account. And after that, if they're coming in the clinics within 5 years of onset of menopause, the replacement therapy, and it will carry a lower risk of stroke. However, the longer it has been since the menopause, like if you're beyond 5 years since menopause and then you start the hormone replacement therapy, you have a higher risk of stroke simply because other risk factors are also surfacing and you're having an augmenting impact on those. These are the risks that we already discussed in pregnancy. This is another unique situation which women can have in pregnancy, which is CVT, which is simply the stroke of the veins. Most of the strokes happen because of the clots in the arteries. Arteries are the vessels which take the blood to the heart, to the brain, and to the body to provide nourishment, whereas veins are the vessels which drain the different organ systems and the vessels which drain the brain. If they get a clot, you can have CVT. Similar symptoms of stroke can occur. In addition, severe headaches and seizures could also occur in the setting of CVT.
One of the best ways to protect a loved one or a friend that may be pregnant that is pregnant and they start talking about unexplained headaches,
Yes.
you ask them to come see one of us immediately,
In the emergency
because
room.
we have to then visualize those veins to make sure they do not develop a venous sinus thrombosis, because this can be very devastating. So the most important risk is that they're hypercoagulable, meaning that their hormones are primed to develop blood clots. This can actually even happen 2 months after they deliver birth. So it's, if the person develops a headache, and you know that they're pregnant and they've never had headaches, guide them to the emergency room so we can visualize their blood vessels.
Okay, and let's say you visualize their blood vessels and you see a CVST, what can you do about it?
We have to give a blood thinning medication. There are several blood thinners that are available, but there are some which are specific for pregnancy. General public knows about Coumadin or warfarin sometimes, but that is the drug which we avoid in pregnancy. There are other drugs known as heparin and Lovenox, which we usually resort to in pregnancy. But it has to be in a hospital setting. It can be in an outpatient setting. This is a chart which is talking about the unique risks that women face, which we have already discussed, but I'll quickly go over it. The risk factors which are less favorable for women, and here we are comparing the risk in women to men. Prevalence-wise, as the women, because women live slightly longer than men, no offense, but we do.
It's
so
true, they live longer.
Just because of that, I guess we have better coping mechanisms. And ability to deal with stress, but they tend to have they tend to be diagnosed more with hypertension in the later age. Migraine has an association with stroke risk. Migraine alone does not cause stroke, but it does during an acute headache. Our blood vessels can spasm, they can narrow out, and they can compromise blood supply. That is one of the mechanisms explained. Again, obesity is slightly more common in women, and that's why it could be directly related to risk factors. Also, diabetes, smoking certainly is a risk factor. One interesting factor is women tend to seek less help and less care, and so they tend to be prescribed the blood thinners as well as cholesterol lowering medicines less than men. Could be because of delayed access to resources, for which reason it happens. And then the unique risk factors in women, I have already touched base about in their different stages of reproductive life. So what can we do about this? Things that we have control over. So we don't have control over our gender, over our age, over our socioeconomic status, but we do have control over certain factors. For instance, if you have hypertension, you get regular checkups from your primary care physician, and eat a balanced diet, Mediterranean diet. Dr. Zacharadis can touch base about that maybe in the Q&A section because of for the sake of time. But balanced diet, and most important, if your doctor is recommending a medication, don't try to avoid that. It doesn't mean that you're a weak person, human being. If you need a medicine, take it. It is going to improve your quality of life. It is going to make sure that you live longer without disability. So if you try to stick to your medication, then take them when prescribed. Another thing is atrial fibrillation. It's simply an abnormal heart rhythm. As we age, our risk of developing an abnormal heart rhythm where our heart does not beat regularly increases our risk of developing clots in the heart, which we eventually throw in the brain, which can cause a stroke. And lifestyle factors, physical inactivity, lack of exercise can contribute, can certainly increase the risk of stroke because all those risk factors are not going to be controlled. And anxiety and stress can also increase the risk, but we can control this by trying to have better coping mechanism, and if not, taking medications for depression also greatly improves the quality of life and our ability to deal with those stressors. So I would recommend patients to take those medicines as recommended.
I often think if people did not have high blood pressure, high blood sugar, and took their blood thinning medicines on AFib, they wouldn't need the three
They
of
won't
us.
need it, so I don't know.
But we're here for that.
Yes. So stroke is the leading cause of long-term disability, and it is the leading preventable cause of disability. So this is the most important fact, that if you recognize the signs and come into the emergency room in a timely fashion, we can save that brain tissue. When it comes to stroke, time matters. Time is brain. The faster you come in, the better we'll be able to take care of you. And these are the signs that we need to watch out for. Numbness or weakness, if a patient has suddenly feels like their face, arm, and leg is numb on one side of the body, or one side of the body has completely gone limp, which means that it's completely paralyzed. Or it could be that it's not completely paralyzed, you're able to lift your arm or leg, but you're not able to hold it up for more than a few seconds, then too it is considered to be a weakness which needs to be addressed. Confusion, trouble getting words out, or stuttering, or not being able to articulate, or not being able to understand what's going around is also a sign of stroke.
Artha, after a long night of call, I feel like I have most of these
symptoms.
What we might call stroke mimics.
Right.
Can you just talk a little bit about some of because I suspect many people are reading those.
I'm feeling this.
Yeah. So any common scenarios where you could tell patients, no, you're okay, that these are common findings that are not stroke symptoms?
That's a very good question. So basically, if the symptoms are sudden, they come out of nowhere and they're intense from the word go, and you know that something is not right. Like you don't walk around with a droop. If you don't have a facial droop at baseline, and someone is like, hey, your face is drooping, and you suddenly are completely numb on one side. A lot of times we have numbness in the tip of our fingers and the tip of our toes because of diabetes. That is not what we consider numbness. Or a numbness which is changing position, like you have it in the leg, then next minute you have it in the right arm, then you have it on the left arm. It's not correlating. But if it's one side of the body, sudden, within the few seconds to minutes it's happening, it is basically the onset. It has to be sudden. 1 minute you're okay, and the next minute you're like, what is this? This doesn't seem right, and you're suddenly not talking. Then that is what is indicating the stroke.
A good stroke mimic could be a migraine.
Yes.
A migraine can lead to somebody, you've seen it in news reporters on TV. Sometimes they'll go on to talk to gibberish because they're actually, instead of a stroke, they're experiencing a migraine. However, you don't know what it is
unless you get evaluated.
You get evaluated, and that's where this Be Fast is: the recognition of a neurologic change, alerting the EMS or family to bring the person to the hospital, nearest stroke center or primary stroke center, to be able to give the different treatments and evaluations.
If it's sudden, just come to the hospital.
Got it. But we are almost out of time. So before we go on, I feel like we should give the audience time to ask questions. Is it possible for someone to read us off a question if there's one in the chat box, or if someone has proffered a question from the audience?
Yes. So our first question from the audience is, are there currently any openly enrolling stroke studies at JFK? If so, how can I obtain more information?
That's a great question. So we have different types of stroke trials. Some of them you do not want to be in because that means you've already suffered a massive stroke, and we're evaluating new devices to pull clots out of the brain. So those are stroke trials which we will potentially enroll you in, because we're always looking for the latest, greatest, most effective technology to unclog the pipes that bring blood from the heart to the brain. So those are some stroke trials we have going on. We do have new trials that help treat aneurysms, so new devices that help treat aneurysms from the inside out. So if you have a brain aneurysm, we may have a new device for you. And finally, probably what you're referring to is we have trials for patients that might be at high risk of a stroke with new medications that might be more effective than prior medications, specifically new types of blood thinners. I would say that potentially we will find a way to get a contact number, so that way you can get in touch with our Stroke Institute, our Neuroscience Institute, to be informed about new ways to prevent stroke, new ways to treat aneurysms, and new ways to pull clots out of the brain.
Our next question is, you mentioned migraines don't cause a stroke, but does it increase your risk or chances of having a stroke?
So migraine itself does not cause a stroke, but the presence of migraine along with other risk factors like hypertension, abnormal cholesterol levels does increase the risk. Only because when a person is having that acute headache, it is causing changes in our blood vessels. It makes the blood vessels narrow, and over time, depending on how frequently you have headaches, you can have what we call subclinical kind of strokes, which you're not seeing them clinically, but you're having those hits in the brain simply because of the compromised blood supply in a very episodic fashion over a lifespan.
Our next question is, what can be some of the signs and symptoms to be aware of if you have a small aneurysm, approximately 2.6 millimeters, in the left ICA?
We're on to you right now. That 2.6.
That's really funny.
Well, let's an aneurysm. The single most important thing to think about is if you ever get the worst headache of your life, whether you know you have an aneurysm or you don't, you have to come into the hospital, because that's the single most important alarm sign that your body's telling you, got to go in. At 2.6 millimeters, it's not large enough to cause a compressive symptom on a cranial nerves or nerve that control the movement of the eye or different other parts of the brain.
Dr.
What do you guys
Jensen,
think?
is it also not true that it will also depend on what that aneurysm looks like, even if it is small, if it looks like it is more predisposed to? So basically the headache and just watching out for red flag signs.
They call hypertension the silent killer.
Yes,
and,
yes.
and aneurysms unfortunately rarely cause symptoms unless they pop. I think most aneurysms nowadays are found incidentally, usually due to a headache workup. And I want to be clear that the vast majority of headaches are not caused by aneurysms. But we do tend to screen patients with migraines or worsening migraines with blood vessel studies of the brain, and that's probably the most common way aneurysms are found. So an aneurysm that you're describing, probably going to be asymptomatic. I think that probably about 99% of unruptured aneurysms remain asymptomatic. They don't cause headaches, they don't cause nausea and vomiting, they don't cause cognitive changes or slurred speech or trouble thinking. They simply are there, lying quiescent until they rupture. And then when they rupture, that's when a third of people die, a third of people are permanently disabled, and if well cared for, a third of people can do remarkably well. We don't recommend screening for brain aneurysms unless you have at least one first-degree relative with a brain aneurysm, simply because it's still uncommon to have an aneurysm. Only about 1 in 50 people in the US have an aneurysm.
So let me tie the two together. So if somebody has an acute neurologic change outside, they come in immediately. They're within 4.5 hours of symptom onset. They have a neurologic change, but you know that they have an aneurysm. Can you give this person TPA or tenecteplase?
Yeah, I mean, what we do is we do the vessel study on all our stroke patients just to make sure that that aneurysm is safe and secure and it's not leaking. And if you're sure that it's not bleeding and leaking, then we can definitely give a blood. And then we closely monitor them, and then we put a consult for our neurointerventionists.
This is a graphic of what an occlusion from a blood clot looks like, which causes an ischemic stroke. And then what you'll see is the blockage, and then you'll see the medicine that we provide to try to open that blood vessel up and thin it away. There's that medicine, the TPA or the tenecteplase, and that is why we are saying time is brain, why you have all this interplay in the ER to get the person from the door to the CAT scan to the medicine or to the catheterization lab so fast.
I think that we are just about out of time. So
Yeah.
How about we entertain one last question before we sign off?
Yes, our final question is, for patients with a history of hemorrhaging and can't use blood thinners, what do you recommend?
That is a conundrum. I'll talk about just one specific incident there, and there could be a couple different scenarios. So if you have atrial fibrillation, which is probably one of the most common causes of stroke in the United States, where the heart quivers and you can develop clots in the heart, and you're deemed too high risk to be on a blood thinner. There's a relatively new device called the Watchman, which is an implantable mesh basket that sits in the area of the heart that tends to develop clot when the heart can't beat as strongly as it normally does. An interventional cardiologist would place that device, and I think that's an excellent alternative to anticoagulation for those deemed too high risk. I'm sure any other scenarios where you might not be able to be on a blood thinner with a different type of stroke?
So it depends on what is the cause of the bleeding. If it is hypertension, then we just recommend control the blood pressures, keep a tighter control, don't let the high upper reading go over 130. Stricter control as compared to the ischemic strokes. And then after we've done serial scans, and once the blood has resolved in the next 2 to 3 months, we can easily put them back on their blood thinners because the mechanism was different. However, patients who've had a spontaneous large bleed and they've had several episodes of those bleeds, simply once you have a big bleed, other than hypertension being the cause, then it just means that your overall risk of having other second bleed or third would be higher, and just it has to be patient to patient. There's another unique situation which is called the cerebral amyloid angiopathy, where we tend to have these bleedings in our superficial areas of the brain. It's a unique situation where some plaques deposit in vessels and just make the vessels very predisposed to breaking and causing frequent hemorrhages. And unfortunately, in that instance, if it is a high grade for sure CAA, then we can't give blood thinners, whether it is obviously like the warfarin and those major blood thinners like Eliquis carry the highest risk, aspirin carries a slightly less risk, and no blood thinners are the best where you can. So it's a patient by patient situation where you have to customize the treatment. You have to look at the overall history, and you have to decide with the patient how you're going to plan the treatment in the future and how you're going to monitor them.
Sadly, I think we're out of time. I think I speak for us all when we say that we feel blessed to do what we do. Once again, it takes an army to treat a patient with a stroke, and we have an incredibly warm, friendly, and collaborative team that works tirelessly to help those with stroke. So, for all of us, I'll let you sign us off. Any final words?
Thank you for joining.
Before we wrap up, if we could just go to the final slide, just so that people can view your contact information. And while you're doing that, there's one last question. Are there any ways that we can reduce our risk of a stroke? And are there things that we can do on a daily basis to prevent strokes? So I think that's from a food or exercise point of view. So while you're pulling up that last slide, if you could just answer that one last question, and then you can wrap it up.
Absolutely. So the most important thing is blood pressure is the #1 risk factor for stroke. And so take it very seriously. If you're getting headaches, if you're having symptoms which are very different, monitor your blood pressure at home, take all those readings and see if majority of the readings are on the higher side. Immediately tell your PCP that this is clinics in the primary care, and it's said that, oh, this could be just a white coat hypertension and patients also say it's only elevated in the doctor's office and not at home. Well, you'll only be sure if you're monitoring it on a regular basis at home as well. Doesn't mean that you have to do it every day, every hour of the day. One reading in the morning, one reading in the evening on alternate days, just to have an idea where your blood pressure is at. And if majority of the readings are over 140, depending on the age as well, then you should reach out to your primary care physician. Diet, of course, salt in a balance, no more than 2 grams of salt in a day if you're already a hypertensive patient. Weight loss is important. Every 10 pounds that we lose, we bring the top blood pressure down by 10 points. Very, very important weight reduction. Also important is diabetes. If you have diabetes, balanced diet, take your medications. Hypertension, diabetes, cholesterol, diet is important, of course, but if you are prescribed a medicine, please take your medications. Don't think that without that medicine, your treatment is, you can treat your problem, because a lot of it is genetics, and it's just how our vessels are made. And despite the best, a lot of patients say, doc, I exercised all my life, I did everything right, yet I have this. So that's where the genetics are factoring in, and medications, if prescribed, have to be taken.
And you are your best caretaker. Smoking is probably the single most harmful thing you can do, because we see it, what it does to the blood vessels, not only to the blood vessels of our neck and our brain, also to our heart and every other organ, our lung. Walking 8,000 to 10,000 steps a day does something tremendous cardiovascularly for us that we know and we cannot quantify.
Or if you can't quantify it, I'm sorry to cut you off, it just means 75 minutes of exercise a week. You can break it off into 20 minutes a day, alternate days, or whichever way you want, but a vigorous kind of exercise where you do a power walk or a brisk walk, or depending on what your exercise regimen is.
And sometimes these small steps don't mean much, but when you add them up and you are consistently and persistently doing it, it gets you better. I think the other part of it, from a diet standpoint, I actually prefer olive oil going out, and I avoid canola oil for the amount of inflammation that, and actually now the newer thing are the microplastics that are found in the carotid disease when they remove them. So certain things to
one
think
question.
about.
Olive
Yeah.
oil can sometimes pose a financial aspect, like it's very expensive. So what are the other alternates that we can use
No,
if we can't use olive?
There's avocado oil,
It's very expensive.
tallow also, beef fat. So there are things that are, even though you're talking about saving money from a business standpoint, but it turns out pretty harmful to us. But I think overall, we really want to thank you for joining us on this webinar. And we want you to know that here at JFK University Medical Center, we're here for your needs, and we're here ready to take care of your family and loved ones.
Thank you for your time.